Hi, nice to see you all. Ravi Savarirayan here from Melbourne, and I'm giving this talk about new treatment options for genetic bone disorders. It's wonderful to be giving this to the ALPI community as a member of the Scientific Advisory Board. Here are my disclosures. All have been disclosed. So today I'm going to talk to you a little bit about the background of what brought around these new therapies and a little bit about skeletal dysplasia. And then I'm going to talk to you about an extremely exciting story, which is basically the story of vosoritide from mouse to market. I'm going to talk about new precision therapies for achondroplasia and also drug repurposing for SMID, metaphyseal dysplasia. We're in the process of beginning trials for many other skeletal dysplasia here in Melbourne, Australia, and I will talk to you about those, I hope, at some point in the future, face to face. My research team here in Melbourne, it's a large team. We have Supriya Raj, who's my research manager. We have 6 research nurses, my sub-investigator, Chloe, who's also a clinical geneticist, and we've recently employed a research dietitian, Penny Island, who's our research physiotherapist in Queensland, and Svein Fredwell, who's our rehabilitation physician in Norway. So a very large and diverse team. Skeletal dysplasia are inherited disorders that affect the development, growth, or maintenance of the human skeleton. And recently, our committee that have been classifying this disorders for many years have met, and we now have 771 entities and 552 genes. And I'm hoping to be able to facilitate as many treatments for people impacted by these conditions as possible during my career. So how did this all start? The big 3 questions my patients ask me is, firstly, what's wrong with my child, which speaks to diagnosis, because without a diagnosis, we can't move forwards, and an accurate diagnosis is important. The next question is, what's going to happen to my child? And that really speaks to natural history, because if we don't understand the natural history of a condition, then we cannot understand the impact on this condition by any potential management. And finally, the final question is, well, what can you do about it? And that really speaks to treatment. And for many years, we weren't really able to answer this last question very well at all. But we are getting better and better at diagnosis. And in fact, we have many different ways of diagnosing a suspected skeletal dysplasia. And one of these are various gene panels. Here is the InVitae panel, which we use here in Australia if we suspect a child has a skeletal dysplasia. And it has 358 genes and many different conditions on this panel. And you can see here it includes many of the very common conditions that we see: achondroplasia, osteogenesis imperfecta, SED, etc. The natural history, it's also important to understand, because we then, without knowing this, we can't understand the impact of a condition in the future. We can't assess the impact of an intervention or measure it. And really, these studies in medicine and skeletal dysplasia are generally lacking. And here is one that we did some time ago now, back in 2007, with a condition called metatropic dysplasia, trying to delineate the clinical and radiographic findings in patients. And these were patients that spanned a 37-year period, and they were patients from as young as 20 weeks of gestation to 70 years of age. And really, this gave us a lot of information about growth and development and complications in adulthood, because before this paper, I think the oldest patient that had been followed was around 11 years of age. So really important information. And here is another similar paper that we wrote, again, a long time ago, almost 20 years ago now, was the natural history of a rare bone dysplasia, chondrodysplasia punctata, a specific type. But most importantly, the 3 patients we had in this study were followed up for 37, 25, and 32 years. So again, we were able to understand the long-term clinical history, the long-term radiographic history, and also very helpful for young children being diagnosed with this condition and their families, because we could give them an idea of what was going to happen in the future. And then finally, this is a study that was recently published, and this is related to the growth study of children with achondroplasia who came into our BioMarin trials that we led in Melbourne. And this was a 7-year prospective multinational study to collect growth information, to collect surgical information and complication history in these 363 children, a very large cohort. So very, very important to establish this. But the final question, and that is, well, what can you do about it, doctor? We're faced with a barren landscape because for so many years there's been nothing. So let me take you through the story of achondroplasia. As you know, it's the most common form of disproportionate short stature, and it's caused by a mutation in a gene, FGFR3, that inhibits bone growth. And there are many comorbidities in people who have achondroplasia. And apart from growth hormone that is used in Japan and really is not a precision therapy for this condition, there have been no approved pharmacological therapies until recently. And so therefore, treatment has been symptomatic. It's been variable and inconsistent from country to country and even within countries. Achondroplasia is a group of conditions in the FGFR3 group. And here is our most recent naming nosology. And you can see here, achondroplasia is listed. It's caused by a mutation in the FGFR3 gene, which also causes the milder condition hypochondroplasia, as well as the more severe condition thanatophoric dysplasia, all FGFR3 conditions. And recently, in order to try and standardize the management of achondroplasia across the world, we have developed some international consensus guidelines, and this was with 55 experts, and several of whom are on the ALPE board, and we came up with 136 recommendations across the lifespan via this process. It's been translated into many languages, including Spanish. And a plain language statement will be coming soon so that consumers and patients can easily get the most out of this statement. And in addition, some years ago, myself with Dr. Will McKenzie and Dr. Clane White set up the Skeletal Dysplasia Management Consortium, and our mission statement is to improve the lives of people with skeletal dysplasia, and you can see the website there. And we have written several guidelines on various conditions that can be freely accessed on the website. Let me turn now to the journey with vosoritide, or BMN 111, as it was called previously, for achondroplasia. And here in this cartoon, you can see a cartilage cell, and in achondroplasia, we have an activated FGFR3 molecule, which acts as an inhibitory signal on bone growth. And vosoritide, which is based on naturally occurring CMP, or C-natriuretic peptide, comes in and blocks this signal at the level of RAF1. And vosoritide had been engineered so that it resisted digestion in the stomach, which meant that it could be given as a daily subcutaneous injection. And the development program for vosoritide really reflects the growth of children with achondroplasia. And we started off in our phase 2 trial in older children, and then we moved into younger children as well. All of these children came into our natural history study here, so we could collect baseline data on them. And you can see here from this growth chart, the 50th percentile growth for children with achondroplasia is in a blue line, and here in the pink line is average stature. And you can see that it's less at all ages for achondroplasia, and it's around 2 centimeters less from around 3 years onwards. And the other thing is that in children with achondroplasia, they lack this acceleration of growth at puberty, the so-called pubertal growth spurt. And here is the program pictorially. We had the phase 1 study, which was to make sure this medication was safe in healthy male adults. And then all of the children that we enrolled into our various studies came into a baseline observational study. They then either rolled in the first study, which was the phase 2 study to test the safety of the molecule, and then the pivotal phase 3 study, the 0 to 5 study, which is about to be published, and then this final study looking specifically at the foramen magnum. And let me talk you through this. This slide really represents the last 12 years of our work. And just to show you that this is from the natural history study, where we were able to develop our own growth charts for children with achondroplasia. You can see here the highest growth velocity for children, for boys and girls, is before 1 year. By 1 year, it's approximately 7.5 centimeters for boys and girls. And from about 3 years onwards, for girls and boys, it's around 3.5 to 4 centimeters. This is important to know if we are looking at an intervention that will increase growth. And you have to, as I've told you, achondroplasia is a disproportionate short stature. So it's important to remember that legs are short, and this can impair functionality and ability to run and to a different center of gravity, which can lead to more fatigue and falling. So basically, in children with achondroplasia, the ratio is closer to 2 from about 4 years onwards, whereas children with achondroplasia, this ratio is closer to 1, meaning the upper and lower segment of the body are equal. And in our phase 2 study, we were basically looking at various doses of vosoritide, and we did this study in 4 cohorts, and I presented this before at ALPI, and we started off with a low dose and moved up by each cohort. And you can see here at baseline, all the children in each cohort were growing at around 4 centimeters a year, which is about right for their age, because they were aged between 5 and 14. But after 6 months and maintained for 42 months, we had an increase in growth velocity in these children treated with either 15 or 30 micrograms per kilogram per day, up to 6 centimeters a year, which is that expected for average statured children. And these results were very, very noticeable. It was the first clinical study in achondroplasia, and basically it established the 15 micrograms per kilogram per day dose as the dose for further studies, further phase 3 pivotal studies. And this is the phase 3 study. The objective was to evaluate the safety and tolerability of this medication. Again, all the children had come into our baseline growth study, but this time they were randomized 1-to-1 to either receive vosoritide at 15 micrograms per kilogram or placebo for 52 weeks. And we recruited children from 5 to 18, double-blinded, meaning no one knew if their patients were getting vosoritide or placebo. And then after 1 year, they all received open-label vosoritide. And here is the results from those studies that were published in 2020. And basically the take-home messages was that the incidence and severity of adverse effects were similar in the treated group with vosoritide versus placebo. And in those given vosoritide, they grew in that 1 year 1.6 centimeters per year more, which was highly significant. And here is the pictorial representation of that. Here at baseline is the beginning of the study when the children were randomized. Those that before they were randomized, both groups were growing at around 3.8 centimeters per year. The group randomized to vosoritide increased their growth velocity to 5.4 centimeters from 4.2, and the group given the placebo, their growth velocity remained essentially the same. And after 1 year, when the placebo group received vosoritide, their growth velocity increased from 3.8 to 5.52. So this is the 2-year data that had been published in 2021, showing conclusively that vosoritide is having a significant effect on linear growth. And in addition, one of the important things is we want to see if this improves body proportionality, and we are seeing improvements of body proportionality that are translating into improved functionality for these children. And here's the publication again in 2021. And then the very, very promising results from the studies in children 5 to 18 led us to begin the infant study, which is in children 0 to 5. And again, this was to evaluate safety and tolerability in this group, but also evaluate the change from baseline. And this study again was in 3 cohorts. They were age cohorts. The first cohort was aged 2 to 5 years. The second from 6 months to 2 years. And finally, 0 to 6 months, very young children. And in these cohorts, sentinel subjects were recruited in the younger ages to see how the medication was tolerated. And in fact, younger children excreted vosoritide faster. So under 2 years old, they received 30 micrograms per kilogram. And before that, they received, after 2 years, they received 15 micrograms per kilogram. And it was a double-blind, placebo-controlled design as well. And this slide looks at height gain after 1 year, looking at the placebo and vosoritide group as compared to average statured children of the same age and sex. So you can see here that after 1 year of treatment, those that got placebo were growing at 78% of their age-matched peers, cohort 2, 74%, cohort 3, 68%. But in those children given vosoritide for 1 year, after 1 year, they had recovered 91% of growth velocity in the 2 to 5 group, 87% in the 6 to 24 months, not so much of an increase in the 0 to 6 months. And that might have been due to small numbers, the fact that we might have used a smaller dose, or measurements were difficult in the youngest group of children. But again, very promising results in terms of height gain, because overall, these medications are going to be for cumulative height gain, cumulative health gain, and function gain, not for 1 year gains. Most importantly, one of the endpoints of the trial was to look at an MRI scan and look specifically at the facial volume and the facial sinus volume and the foramen magnum area in these children. Very important, because we believe all children with achondroplasia have a small foramen magnum, which is the big hole where the brain becomes the spinal cord. And basically, we think this is causing the excess amounts of severe medical problems and sometimes infant death in this group. And in cohorts 1 and 2, aged 2 to 5 and 6 months to 2 years, we saw no differences. But in the youngest cohort, we saw a significant difference in the facial volume, sinus volume, and foramen magnum area in the group given vosoritide versus placebo. I think this is very important because it may well lead to a decreased incidence of adverse medical events in these children, including sudden death and the need for neurosurgery. It makes sense because the foramen magnum probably stops growing in children with achondroplasia at around 6 months. So we have a small window of opportunity to treat these children. And I've recently been in Japan talking to the Japanese doctors where they can treat from birth. And this will be one of the very important things to follow. And finally, we are looking at a study where we're looking at the foramen magnum at risk study. And this study is to look specifically to see whether vosoritide treatment can decrease the incidence of adverse events like sudden death and the need for neurosurgery in children. And in these children, we screen these children, and in those that are at risk of needing an operation, they're randomized to either vosoritide plus standard of care or just standard of care, which is careful observation and further MRI for 2 years. And then for the next 3 years, they'll all receive vosoritide to see whether the group given vosoritide have a decreased incidence of neurosurgical complications. And of course, all of this work culminated with the approval of vosoritide as a treatment for achondroplasia from 2 years and above by the European Union on the 27th of August, 2021. And since then, it's been improved in numerous countries, including Australia, where we are using the medication from 2 years, and it has actually been approved by our medical people from birth, and same in Japan. So very, very exciting. And I had the pleasure of going to Canberra and announced that not only was this medication improved in Australia, but from the 1st of May this year, it will be reimbursed for all Australian children and their families, meaning that instead of costing 330,000 Australian dollars a year, it will cost about $30 per year, which is the cost of the prescription for families. So very important for me, because it's important that all treatments can be accessible to all people and not just people who have money. And so this has been a great outcome. It was only 4 years from the New England Journal paper to market. And here is me writing one of the very first scripts for an Australian child to receive vosoritide. So extremely, extremely good outcome, but much more work to do. And we are leading a lot of other potential therapies for achondroplasia. We are working with QED Therapeutics, who have an oral tyrosine kinase inhibitor. And basically, this is an oral medication that comes in and blocks the mutation because it's a tyrosine kinase inhibitor. And basically, it blocks this mutation, allowing normal bone growth to resume. And this was very much shown that when we treated the mutated mouse with achondroplasia with this medication, the long bones looked much more normal, as did the growth plate. Most importantly, you can see here the foramen magnum in the achondroplasia mouse is much smaller than the wild type, but the treated mouse is looking much more like the wild type, as well as facial skeleton improvements as well, and increase in vertebral body length from L1 to L4 to L6, which is important because we believe this might help in terms of spinal stenosis, which is present in adults with achondroplasia. And this is reflected by an increased disc width, which means the spinal cord, which runs here, has more space. So we think it's very important, and we think that it will potentially impact the most severe medical complications of achondroplasia, which are foramen magnum stenosis and spinal stenosis in infants and adults, respectively. Very exciting. And we have completed these trials. The first trial, these are called the PROPEL trials. And basically, these are in children 2.5 to 17-year-old. And these were dose escalation trials ranging from 0.016 per day to 0.25. Remembering this is an oral medication, and we've finished those trials. And I've recently reported the month 6 results, which basically show in the biggest cohort, which is in the highest dose cohort, which is 0.25 milligrams per day. We had 12 children enrolled. And you can see here that in this cohort, cohort 5, we had a significant change from baseline of 3 centimeters per year, with an 80% response rate and a mean annualized growth velocity of 6.7 in these children, who should be growing closer to 3.5 to 4 centimeters per year. So extremely important. And this was reflected by an increase in collagen type 10 fragment in the blood, which is a reflector that this is due to increased bone formation. So really, we had a very good response with no side effects as well, and no advancement of bone age. So a very, very promising data from this phase 2 study. And here you can see it again. The average of cohort 5 was 3 centimeters per year above baseline. You can see it there. And which is very, very promising, and a very high response rate. And out of those, 8 out of 10 who responded, the response rate was an increase of growth velocity of 3.8 centimeters per year. So we hope that this is also going to be seen in the spine, and if the children are treated young enough, in the foramen magnum, which will be wonderful in terms of health outcomes. We're also leading the weekly subcutaneous injection of CMP, which is where CMP is conjugated to a linker and then is broken down slowly over time like a long release action. So this is a weekly injection rather than a daily injection. And we've recently released these results, and they're very soon to be published as well, that in the highest dose range, we saw a significant increase in annualized growth velocity and height standard deviation scores compared to the pooled placebo over time. You can see this dose, which is 100 micrograms per kilogram per week, as once weekly subcutaneous injection, significantly increased to the placebo. So that's exciting as well. And in summary, we've gone from having nothing for achondroplasia to vosoritide being approved, the weekly injection and the oral injection being further investigated. Sanofi also have a product that we are about to start trials with, which is an antibody, and there's another oral product in the pipeline as well. So very, very exciting. And just as a note, as was mentioned in recently, the trial that Pfizer was running with Recefacept was stopped because of lack of efficacy. I'd like to turn to another condition that we are working with, and this is a bone dysplasia called Schmid dysplasia, where children have bowed legs and a waddling gait, and they will often need surgery for hip deformity. And we and others have shown various mutations in type 10 collagen, which is important for the growth plate. And this basically causes problems with folding of the type 10 collagen and sets off a series of events that causes these bone issues. And a very common anti-epileptic medication called carbamazepine was found to overcome this defect, and it has good mouse proof of concept proof. And so we are currently in the final parts of a treatment trial in these patients to try and affect pain, improve growth, and improve quality of life, and decrease the need for surgery. And this was funded through a European Horizon 2020 grant. So overall, we're at a very exciting time. As I said, my team and I are running 17 different trials now for various forms of skeletal dysplasia. We want to rapidly move from diagnosis to an intervention through good clinical trials, through fast pipelines, industry partners. Obviously, we need to have consumer partners like Alpay as well, so we can bring game-changing and life-changing new therapies to our patients. And it must be remembered that in all of this, although a lot of my work is now bringing new therapies, these are just one options for families, and these must be combined with advocacy and lifelong patient care and community of support for people with skeletal dysplasias, as foundations like Alpay know all too well. Although the primary endpoint of these trials might be growth velocity, the primary goal is always better health. And it's important that whatever new treatments come along, we have equity of access, not just in countries, but between countries. And that's something we need to still work on. So I would like to acknowledge all of the many people that have done this work across the world, especially my team and the Australian government and others who help sponsor me. I hope that I will be able to join you all in person in Gijón to present follow-up on all of this work in the near future. Thank you very much for your attention.